Good morning. As is usual, we have a few minutes before the beginning of the presentation for some announcements. First announcement is next week we will not meet in this building. We will meet in the CTR building for our grand rounds. So this room had been reserved for something else. So we've got the CTR building. So we'll try to put signage around and please talk to everybody that you know might be coming, because we know how it's not fun to come one place and realize that you're in a different meeting. Second is just a follow-up on COVID-19 coronavirus. We have none in Louisville. We do have that bio lab level 3. They have the virus. It's, they're doing experiments on it, and the goal, Dr. Julio Ramirez and his team are actually trying to develop a rapid PCR testing. And the reason for that is the CDC has a limited amount of test kits, and you have to have a travel history, and if it's, basically they're only testing certain people, they're not testing others. And so it gets kind of confusing in flu season if someone has a respiratory illness and a fever. It's confusing now that we have some community outbreaks. So the goal with his team is that they may have a test that's available for Louisville for all of the emergency treatment centers. And we're working now on calling that ground zero. We have none, but we want to basically do some dry runs with our emergency preparedness team of how we're going to intake people, how we're going to test people, and then sequester them and send them home until we have a result back, which could be back in 24 hours. So that, I think, is really good news, that we're going to be proactive at Louisville instead of reactive, and I think that's the great news. So without further information, I would like Mohammed to come up and introduce our speaker for the day.
Good morning, everyone. It's my pleasure to introduce Jose Gomez from the Pulmonary Division at Yale. Jose, native of Colombia, came to the U.S. and did his residency at one of Yale-affiliated residency program, and followed by a fellowship at Yale, finishing in 2012. And started his academic career there as an instructor of medicine, and then now he's an assistant professor. Jose is a classic scientist, but he's also a very active clinician. He has his own clinic about difficult to control asthma and severe asthma. So I think the talk will be very relevant. The good news that we have about him is that he's a rising star as a scientist. Yesterday just received a good news about his R01 grant, so we were very happy and pleased for him. Had numerous publications in a very short period of time, active in ATS. So I'm pretty sure in a few years you're going to hear more and more about him. He's also a fantastic guy to talk to and chat, and we're looking forward to have a very nice talk today about asthma. So I want to thank him for coming today, and Jose.
Good morning. Can you hear me okay? So good morning, and thank you so much for the invitation. Thank you for the nice introduction. Today I'm going to be talking about precision medicine in asthma in 2020. I want to start by saying I have no conflicts of interest that will affect this presentation. My goals today are to discuss some of the novel therapies in asthma, and also talk a little bit about some of the challenges that we face when we're dealing with in patients with asthma, severe asthma particularly, and also try to discuss some of the new methods to characterize patients and identify potential therapeutic targets. When we hear this concept of precision medicine, we think about a lot of different things. And perhaps the most important thing is to have a good definition that is simple enough, but that also conveys a lot of the elements that go into this. And this is perhaps one of the best definitions by Collins and Vermes that mentions that precision medicine are prevention and treatment strategies that take individual variability into account. That's not to say that that's not what we do every single day when we're dealing with patients, but what they're making reference to is how can we scale this across the health system? How can we account for different levels of variability? And that's where the novelty part of this comes into play. When we talk about precision medicine, typically we think also about some of the technology that powers this precision medicine. And if we want to think about like 3 key technologies that help us advance precision medicine, these are 3 of those: increased computing power, better connectivity, and improved measurements. When we talk about increased computing power, this is perhaps a good illustration of how over several decades we've had exponential growth in the capacity to do computation, reaching the level of the human brain in a chip. And this is something that is currently being used for a lot of these applications with artificial intelligence, despite the fact that the concept of artificial intelligence has been around for several decades. A second technology powering precision medicine is this concept of connectivity. And this is something that we see every single day in our lives. We depend a lot on internet. And as you can see in this graph, the penetration of internet across the world, and this is a relatively old slide, but what it demonstrates is that currently it's very easy to share information, and that sharing of information helps us integrate a lot of these observations that we can capture. And the third technology that powers precision medicine is this concept of improved measurements. And this is where I'm going to be spending a lot of my time today, is discussing some of the technologies that help us understand that individual variability and that help us develop this precision medicine in asthma. What you see here, for example, you see different levels of measurements that we can take from patients, going from the genome to gene expression, better measurements both at the tissue level and at the physiologic level that ultimately will help us treat our patients better. So before we go into the specifics about how can we conceive precision medicine in asthma, it's important to think about, like, can we use precision medicine to transform a disease? And the best example for this is a different airway disease, a separate airway disease than asthma, and that is cystic fibrosis. When we think about cystic fibrosis, a monogenic disorder that affects not only the lungs but other organs, we have to go back to the history. And something that we see in a relatively short span of 30 years from the identification of the CF gene, we've seen significant advances in our ability to understand how those molecular changes in the CFTR channel lead to different subphenotypes of disease. And perhaps the biggest achievement from all of this development here is this observation from this publication from last year that demonstrated that the new types of channel correctors for CFTR have the potential to improve your FEV1 by almost a liter in approximately a month. And in addition to that, being associated with improvement in sodium sweat chloride concentration, reflecting a correction of the function of the channel in up to 90% of patients with CF. So this is a great example. This is something that, in a relatively short period of time, you're able to integrate genetics, genomics, molecular medicine into new therapies And that's something that we want to use as a blueprint in asthma and other diseases to be able to change these types of problems. When we think about asthma in 2020, it's very important to recognize that asthma, the way we're conceiving asthma now, is very different than what it was in the past. And an important distinction here is that when we think about asthma, asthma is a syndrome rather than a single disease. And what I mean by that is that when we think about a syndrome, we're thinking about multiple different problems that are characterized by airway inflammation and airway hyperresponsiveness and lead to these symptoms, but that can be treated very different and can also respond very differently to therapies. Perhaps the strongest association that we have when we think about asthma is this connection between asthma and Th2 inflammation. And when we think about Th2 inflammation, there are some cytokines that are involved in the pathogenesis of the disease, and that can, that affect different features of asthma. And those include the synthesis of IgE by B cells, also eosinophil differentiation, recruitment and activation, and mast cell differentiation. So the combination of all of these features at the molecular level lead to airway inflammation, and typically they're controlled by these cytokines that we're gonna circle back to this. However, one of the biggest challenges now that when we think about asthma, and the reason why we're calling it a syndrome rather than a single disease, has to do with heterogeneity. So when you hear the term heterogeneity in asthma, we're talking about this. We see that across the lifespan. Typically, childhood asthma, one of the most common types of asthma, is associated with this strong Th2 response that I just mentioned before. However, as we get older, you start seeing some other non-Th2 types of asthma that tend to appear in at an adult age. And in addition to that, you get to see that in the upper range of severity, upper part of the severity spectrum, you start seeing some subtypes of asthma that are not common in the less severe cases, suggesting that there are multiple factors at play here. In addition to inflammation, you also see some other things that can potentially lead to airway inflammation and bronchial hyperresponsiveness. Some of those things include secondhand smoking, for example, and other types of inflammation that are less well known than type 2 inflammation. So before we start talking about new therapies, I wanted to bring you up to speed in terms of like how we conceptualized asthma 10 years ago and what has changed over the last 10 years and how we can use this as a platform to see what asthma is going to be, what it's going to look like over in the future. When we think about asthma in the 40s to 60s, it was typically conceived as a disease of the airway hyperreactivity. So you would see a lot of bronchoconstriction, but it was not thought as much as an inflammatory disease. Now, over the 60s and 70s, we started seeing the introduction of inhaled corticosteroids, and over the last 20 years, this concept of airway inflammation has been developed further to lead us to what we have now. And obviously, you're probably familiar with some of the therapies that we can use for asthma that include long-acting beta agonists, leukotriene receptor antagonists, and omalizumab, which is one of the biologics that we use for asthma. I want to talk about one of our patients. This was one of the first patients I saw in my clinic when I transitioned to faculty. So Mr. JP presented in 2012, 52-year-old African-American man that was seen in the primary care clinic, had a history of childhood onset asthma with daily symptoms of shortness of breath, chest tightness, and occasional dry cough. He had 2 exacerbations that required ED visits. In the year prior to his visit in our center, he was on high-dose inhaled corticosteroids, long-acting beta agonist, and leukotriene receptor antagonist, and his lung function a year prior showed mild airflow obstruction. Given that his challenges with asthma, he was referred to our center for evaluation by his primary care physician. Just a brief note about our center, the Yale Center for Asthma and Airway Disease. Our focus is to provide specialized care for patients with asthma and advanced airway disease. We're the only dedicated asthma center between New York and Boston, and we're pretty active both in clinical care but also in translational research and investigational drugs. When he came to our clinic, we performed the typical workup, barometry, FeNO, IgE, and what we found is that his lung function was worse than the year before. You see that he has now moderate airflow obstruction, however, still having bronchodilator reversibility. His FeNO was 43, and just to give you an idea of what a normal value, we typically use 30 as our cutoff. So he had an elevated FeNO, and he also had an elevated serum IgE with positivity to multiple aeroallergens. So when I saw him for that first time, one of the important things thinking about this patient was thinking about also the biomarkers that helped me stratify his potential response or maybe identify a specific therapeutic target for him. And at the time, in 2012, the only thing that we had available to us was omalizumab, which is an antibody against IgE, and it blocks this part of the molecular response in Th2 inflammation. So we ended up giving him a trial of omalizumab for a year, but despite that, and something that one of the reasons why we use omalizumab is because it's been associated with decreased rates of exacerbations and also improved quality of life in our patients. However, despite treating him with omalizumab, the patients continued to be symptomatic, and after a year, we had to come back and say, like, is there anything else that we can do for you? Is there anything that we can do? And 7 years ago, the new kid in the block was bronchial thermoplasty. For those of you that are not familiar with bronchial thermoplasty, I'm going to show you a short video that describes the procedure better than I can do without illustrations.
During bronchial thermoplasty, a small flexible tube is advanced into the airway through a standard flexible bronchoscope placed through the mouth or nose. No incision is required. The Alair device has an expandable wire electrode array at the tip, and when it is expanded, the four arms of the electrode array come in contact with and fit snugly against the airway wall. The expanded electrode array will then deliver controlled radio frequency energy for about 10 seconds to heat the airway smooth muscle.
So this treatment is administered in 3 separate sessions. And typically we treat the right lower lobe first, left lower lobe second, and both upper lobes in the third session. And one of the illustrations from this treatment is that when you use bronchial thermoplasty in the airway, what you're seeing here is a sectional cut this is from an animal, from a dog. And this airway was treated with bronchial thermoplasty. This was not. And after administration of histamine, one of the mediators of airway inflammation, you can see a pretty significant difference between the airway lumen in the treated airway versus untreated airway. When we look at the histology of those segments treated with bronchial thermoplasty, you're also able to see that in the untreated airway, you have this band of airway smooth muscle in the submucosa. However, that disappears after treatment with radiofrequency, suggesting that that's probably one of the mechanisms that leads to this improvement in lung function and decreased symptoms. One of the observations from this is that the response that you expect to see with bronchial thermoplasty is improvement in quality of life and also decrease in healthcare utilization. And this is something that's been seen over the last 10 years consistently in both the original trial that led to the approval of this therapy, but also in the registry that followed this approval. One of the biggest challenges with this therapy, and probably one of the reasons why you don't see it as often, is insurance. A lot of insurances don't cover this treatment, and access has been a challenge, and that's probably one of the reasons why we don't see it as often. The other challenge that we see too is that given that we've had relatively limited experience after market approval, it's challenging to determine which patients are going to respond best to some of this therapy. To give you a follow-up on our patient, so after he was treated with bronchial thermoplasty, he had decreased use of inhaled corticosteroids, but he's had 2 hospitalizations for severe asthma exacerbations in the last 6 years, suggesting that even though we were able to improve his symptoms, we were able to improve the requirements for treatment. He's still having issues with exacerbations, which is the next frontier in our therapy for asthma. A second patient presented a few years later in our clinic, and this is her description. So in 2015, 5 years ago, Ms. AR presented, self-referred to our center. She was diagnosed with asthma at age 43, had daily symptoms of shortness of breath, chest tightness, unproductive cough, and was hospitalized once in the year before evaluation. She was also treated with 4 courses of antibiotics and steroids in the 8 months before her referral. And she was on high-dose inhaled corticosteroids, long-acting beta agonists, leukotriene receptor antagonists, and tiotropium. And her spirometry showed moderate airflow obstruction with bronchodilator response. When we looked at her numbers, what you see here in contrast with our previous patient is you see that now we're including the blood eosinophil counts. And in addition to that, we were also able to, as part of our research program, we were also able to collect sputum. And the main signal that I want to highlight here is the fact that her blood eosinophil counts were elevated 6 months before her visit. However, were suppressed at the time of her visit because she was on oral steroids. The second piece that I want to highlight here is that in contrast with our previous patient, even though she had a similar pattern in lung function and a similar elevation of her FeNO, her IgE was low and her numbers, she didn't have any specific IgE. When we did the sputum analysis, you see that she had a 3% eosinophils in the sputum. Just for your reference, 2% is typically the cutoff to say that this is elevated. So in summary, what we're seeing here, we have a patient with severe asthma that has no IgE, meaning that she doesn't have severe allergic asthma, but that there's an eosinophilic signal. And by eosinophilic signal, I mean a blood eosinophil count greater than 300. Typically, to administer this therapy, we can typically go as low as 150 cells per microliter, and with a history of exacerbations. So the message here is that eosinophils are key effectors of the IL-5 response. And in the same way that I highlighted IgE here, you can see that this is downstream of this Th2 cell. You also have some other mediators like IL-5, a Th2 cytokine, that is associated with increased activation of eosinophils, and that is associated with airway inflammation. An important demonstration of how IL-5 can be targeted therapeutically was this trial on mepolizumab. Mepolizumab is an anti-IL-5 agent that has demonstrated in patients with severe eosinophilic asthma that you can not only improve eosinophils in the sputum and blood, but that decrease is also associated with a reduction in exacerbation rates compared to placebo. What you see here is that after administration of mepolizumab, there's suppression of eosinophils in the sputum, and similarly, there's suppression of eosinophil counts in the blood of these patients compared to placebo. In addition to mepolizumab, two other agents, reslizumab is another one of those, demonstrated that the same effect, that after you treat patients with reslizumab, you see a reduction in exacerbations. So just coming back to our milestones in asthma, over the last 10 years, we've seen at least 3 new therapies come to help us. First of all, bronchial thermoplasty, also the introduction of long-acting muscarinic antagonists, and the introduction of anti-IL-5 agents. In addition to these two, there's a third one that is called benralizumab that is also used for patients with elevated blood eosinophils. What has happened with this patient is over the last 5 years, she was started on mepolizumab injections, and she had a significant improvement in daily symptoms. However, she's still needing prednisone, a major challenge for some of these patients, despite the fact that mepolizumab suppresses eosinophil counts. And in addition to that, she's also had multiple exacerbations requiring hospitalization, suggesting that perhaps there are other factors that affect disease activity that we're not targeting, even though we have these new therapies. The most recent introduction in specific targeting of patients with asthma has been this anti-IL-5, anti-IL-13 agent targeting of this pathway. And it starts with a story 12 years ago that was based on gene expression of the airway. So what you see here is each column is a patient, and every row is the expression of each one of these genes. So in this study, patients with asthma underwent bronchoscopy, and there were some brushes of the airway epithelium, and gene expression was measured in those patients. And what you see here in this heat map is that patients with high expression of this Th2 signature were not only distinct from these patients with low expression of this Th2 signature, but had elevated interleukin-13 expression in their blood. One of the things that you see is that IL-13 induces the synthesis of the expression of these genes. And importantly, the first one, periostin, that is synthesized in the airway epithelium, but is also secreted into the airway wall and makes it into the circulation, making it an interesting biomarker for inflammation associated with IL-13. This led to a demonstration that in patients treated with an anti-IL-13 agent, stratified by periostin levels, you see that patients in the high periostin subgroup had better improvements in their lung function, FEV1, compared to patients with low periostin, suggesting that this is a potential biomarker for anti-IL-13 response, similar to what we saw with eosinophils in the anti-IL-5 agents. However, perhaps one of the biggest challenges to precision medicine that I was mentioning before is that heterogeneity, sometimes plays an important role in therapeutic responses too. And what you see here is that despite these promising results on using this biomarker to target this pathway, you see that in phase 3 studies, that was not the case. That didn't hold true, and this program was completely discontinued after that. However, a different approach targeting rather than the IL-13 molecule itself, targeting the receptor for it, that is a dual, is targeting both the receptor for IL-4 and IL-13, demonstrated improvements in patients with high Th2 inflammation. And this is the new medication that we've been using in patients with severe asthma that is called dupilumab. So just to summarize, over the last 10 years, we've had the opportunity to access new therapies for our patients, a lot of new agents targeting Th2 inflammation. They're typically used in patients with moderate to severe asthma with frequent exacerbations. And in addition to that, we've been able to get a few biomarkers, not a lot of biomarker development in asthma, and that's been a major challenge to identifying subgroups of patients with severe disease. As you can see here, and I've presented to you before, there's this marker called YKL-40, and I'm going to talk a little bit more about that in the next few slides. So an important message here is that even though we made significant progress in treating Th2 inflammation, we still have a whole other group of patients that still have severe disease, that still have airway inflammation, increased morbidity, but that we don't have specific agents for. And that they're the future of our treatments for personalized medicine. So one of the important things when we're trying to understand this disease, or any disease, is to understand what is the biological underpinning. And one of the things that we feel like is an important part of the framework to do this is characterizing and classifying patients. So over the last 10 years, there's been a lot of interest in using machine learning approaches to classify patients. And I'm just going to talk to you about one of these approaches. So clustering is a popular approach in which we know that the population at large is heterogeneous. So if you think about this as a group of our patients, you know that some patients are more like each other, and however, sometimes it's difficult to identify what's different about them, what is common about them. And if we represent that in different colors, we can see that perhaps this patient is more similar to this one and is similar to this one. So how can we do that using different approaches, analytical approaches? One of the things that we can do is take these improved measurements that I mentioned to you as a technology powering precision medicine, and taking that phenotyping that we cannot collect in the clinic or that we can collect in the course of clinical studies, and use algorithms, including clustering algorithms, that allow us to identify these specific subgroups or clusters of patients that have similar characteristics. One of these approaches was derived, for example, from the Severe Asthma Research Program, which is the biggest research program for asthma in the United States. And 10 years ago, what they did is they looked at clinical characteristics that were collected as part of the study and identified some of the key features that drive cluster classification. So what you see here is from cluster 1 to cluster 5, you have increased disease severity, and there are a couple of features that drive that severity, and those include lung function and age of onset, suggesting that using this machine learning approach, we can potentially identify patients at the higher end of the spectrum, of severity of spectrum, that can be targeted. One of the major challenges to the SARP clusters is that they were only based on clinical characteristics. They were not based, they didn't have any diagnostic companion, if we think about it. And a second challenge from this approach is that it wasn't reproducible in other populations, including populations outside of the United States. So the message from this is that even though clinically we can identify these subtypes, biologically we're not able to identify these subgroups, leading us to try to identify new biomarkers to classify patients better. And that's where one of the markers that we have identified comes into play. So what you see here is a study published 13 years ago that demonstrated that this protein, YKL40, was elevated in patients with severe disease, in the blood of patients with severe disease. YKL40 is a chitinase-like protein, and it's part of a family of molecules that are involved in chewing up chitin. Chitin is the second most abundant polysaccharide in the world. It's present in the fungus wall. It's also what makes the exoskeleton of insects, including cockroaches. So that molecule is bound to this. That can be bound to this protein. But it's not chewed, it's not cleaved by this protein. That's what makes it a chitinase-like protein. So basically, what you see here is that not only YKL40 is elevated in the circulation of patients, but it's also associated with increased airway inflammation in patients with severe asthma. So what you see is that there's accumulation of YKL40 in the bronchial submucosa, airway epithelium, and inflammatory cells. Importantly, those inflammatory cells are macrophages and neutrophils. And that contrast is important because when you think about it, about the previous cases, the previous slides when I was telling you about eosinophilic asthma, we see that perhaps YKL40 is a biomarker that tells us something about non-Th2 inflammation. And the question is, how can we integrate this molecule to a more modern way of classifying patients? So in our research, what we do is, again, we try to take this improved quantification of molecules and try to bring this back to the patient. And one of those molecules in this case is YKL40. So what we did is we applied clustering to patients with severe asthma and using serum levels of YKL40. And what we were able to identify, identify 4 groups of patients with based on YKL40 levels and other clinical characteristics. And what you see is that clusters 3 and 4 had moderate and high elevations of serum YKL40. But in addition to, in 3 different cohorts, including SARP and an NYU cohort. But in addition to that, we're able to see that using this classification method can also help us identify that patients that have moderate elevations of YKL40, not the highest elevation, they're the ones that have the worst lung function. You see here is FEV1, post-bronchodilator. So these patients, even after bronchodilator, have significant airflow obstruction compared to patients in clusters 1 and cluster 2, followed by cluster 4 that had the highest level of YKL40 but had less severe airflow obstruction than patients in cluster 3, suggesting that the important feature here is not only levels of YKL40, but everything else that is accompanying that specific classification. Other characteristics that were important, that were different between these subgroups include this. I just want to call your attention to clusters 3 and clusters 4. I mentioned that a big issue when we're looking at asthma over the lifespan is that we have differences between early onset, adult onset asthma. And this classification recapitulates that in an unsupervised fashion. What you see is that clusters 3 and clusters 4 that are characterized by different levels of YKL-40 and different levels of lung function are also differentiated by age of onset. And very important, they're not different in their atopy status. You can still have Th2 inflammation, be allergic, but that is not what separates you in these clusters, suggesting that in addition to having some Th2 inflammation, there may be other factors at play that lead you to this distinct phenotype. An additional observation of this is when we look at clusters of patients with asthma using this approach, we see that patients in cluster 3, the ones with moderate levels of YKL-40 and poor airway function, see that they had pretty high rates of intubation, suggesting that YKL-40 may also be a marker of airway remodeling in patients with history of intubation. Additional measures, when we were able to look at these patients in these clusters, we were also able to see that those in clusters 1 and 2 had lower levels of airway neutrophils in the sputum compared to patients in clusters 3 and 4. And when we measure gene expression of type 2 markers or Th2 markers in the sputum, we see that cluster 2 is the one with the highest type 2 inflammation compared to patients in clusters 3 and 4, particularly 4, that has less type 2 inflammation based on gene expression, suggesting that clusters 3 and 4 may be non-Th2 clusters. In addition to that, we were able to measure not only these type 2 genes, but we also measure genome-wide expression, meaning that we were able to measure the expression of 23,000 genes in the airway. And similar to what I showed you on that previous heat map, what you see here on each column is each column represents a patient. Each row represents a different gene. You see that in patients with cluster 3 and cluster 4 are different than healthy controls and have a very specific pathway expression compare, that makes them distinct, clusters 3 and clusters 4, suggesting that there's, in addition to having different levels of YKL-40, different lung function, you have also different pathways expressed in the airway. So just to summarize where we've been so far, is I've shown you how we're approaching asthma at the severe end of the spectrum, new therapies that have come out over the last 10 years, also the development of new classification methods over the last 10 years to help us identify those subgroups that we can potentially target more specifically. And now what we're trying to do is we're trying to use that information to help us inform the future of precision medicine in asthma. Now, we've only talked about therapeutics and classification, but perhaps the next frontier in asthma is how can we prevent asthma? And there are very interesting studies coming out now looking at, for example, vitamin D supplementations prior to, in pregnant women to try and prevent asthma in their offspring. And that's something that we're very excited about. Also, we want to continue to evolve these classification systems, and we also want to understand better what's different about our environment that leads to different phenotypic outputs in asthma. An important update, so I've talked a lot about severe asthma, but perhaps the most exciting part about how we're changing asthma care these days is at the lower end of the spectrum. Remember that I told you that historically asthma has been thought of a disease of bronchoconstriction. So now the recognition that it's a syndrome of bronchoconstriction and also airway inflammation has led to significant changes in how we approach it at the lower end of the spectrum. So now the GINA guidelines, the asthma guidelines, the most recent iteration, shows that in patients with mild disease, mild and moderate disease, instead of using albuterol for rescue, we can use, as needed, low-dose inhaled corticosteroids and formoterol, a long-acting beta agonist, suggesting that, and the studies have demonstrated that that strategy is not inferior to using albuterol. So the important message here is that if your patient is symptomatic, most likely it's not only bronchoconstriction, but there's also a component of airway inflammation. And by using these medications, PRN, in the lower end of the spectrum, which is the majority of patients with asthma, we can potentially decrease morbidity and also have a better approach, understanding what's driving asthma, which is mainly inflammation. And perhaps the most important local part of the talk, is this, and it's something that I think is going to transform how we can approach asthma. What you see here, you're probably more familiar with this map than I am, but what I wanted to highlight here is that using mobile devices, using an inhaler that is paired with either with a hub or with your phone, you can potentially measure how many actuations of an inhaler you have, which can help you understand how your patient is using asthma. But more importantly here, the demonstration from this study that was performed here in Louisville is that you can see that in some area, over the course of 1 year, you can see some areas in the county that have higher concentration, higher use of the inhaler, of the rescue inhaler, compared to other parts of the county, suggesting that, and I think these are highways, right? So when you look at some of these pockets here, you see that some areas of here have higher use of medication. So this can not only help you understand what's variable about your patient, but it also helps inform policy. It also helps inform how we can potentially change our environment, improve, like guide, for example, like traffic, or be able to plant some more trees. So a lot of things that go into care of our patients can be potentially we can probably benefit from this technology, and that's, I would say, the next frontier on our care. So to conclude, over the last 10 years, we've seen a pretty significant influx of interventions for patients, particularly at the severe end of the spectrum. We have, thankfully, we have a lot of armamentarium to treat patients with type 2 high disease. However, one of the challenges is that we still need to understand a little bit better the other half of the group of patients, the patients with non-type 2 inflammation, to help us guide these precision medicine approaches. In addition to that, we have novel machine learning methods that help us classify patients based on disease severity. And also, characterizing these patients can help us develop new therapies. And like as I mentioned, our knowledge of non-type 2 inflammation in asthma is still underdeveloped, and that's something that we're actively working on. I want to conclude by thanking you for listening, for spending this last hour here, and also thank you for the invitation. And I'm open for questions. Thank you so much. Yes. Yes. Thank you. Right. Right. So that's for those listening to us remotely. The comment is that asthma is the main cause of absenteeism in schools here in Louisville. It's a significant burden, and the question is if we have similar partnerships with in our clinic with other stakeholders to try and improve this issue in New Haven. Just to give you an idea, New Haven has a higher rate of asthma compared to other parts of Connecticut. So we have a similar problem in terms of absenteeism, not only from school, but also from work. I'm an adult pulmonologist, so I tend to work, like obviously in an older population. But yes, there's been our pediatric pulmonology program is very involved with kind of like the school system in New Haven to try and target patients like children with high risk of asthma. And I think one important thing in asthma too, and talking about environment, is that it's something that is unrecognized, but particularly in urban schools, in places where you don't have a lot of infrastructure, or it's an older infrastructure, older buildings, you start seeing a lot of not only like dust, but a lot of infestations, for example, with cockroaches, mice, that lead to more aeroallergens for children. So eventually, part of the increased symptomatology in them can be explained by the school itself, right? So in a way, it's like school exacerbated asthma, and that's something that is not well known, but it's something that is gaining a lot more attention, particularly in the urban setting. So yeah, just to reply to your comments, I believe that obviously we can treat symptoms, but that's not what's going to make our patients better. We also need to treat environments. We also need to recognize how we can manipulate that. And for that, we cannot work alone. We need policy. We need changes that allow us to intervene on those factors. Yeah, thank you. Yes. Great. So the question is, in patients with high chitinase, high YKL-40, any current treatment or treatment that is being developed? The answer is yes. Right now, our center has been funded to develop a new biologic agent targeting high YKL-40. And it's something that we're working on actively, and we're trying to potentially use our cluster approach to identify patients that may benefit from this specific targeting of high YKL-40. Thanks. It's not available commercially, so we have a lot of expertise with this assay. So if anything, at some point, it may, if we're probably going to use it at some point, we're going to need something like a CLIA assay or some sort of way of measuring this for patients. So yeah. Yes. Right. 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 Yeah, so social issues associated with poorly controlled asthma, I would say that is an important concern. We have a lot of patients that are covered by Medicaid, like the most vulnerable population in our state, and a lot of the severity is concentrated in that group of patients. And when you look at some of the factors that drive some of that, they include particularly housing stock. One of the challenges with housing is that you have some places that have very poor, like they have a lot of humidity, or that have a lot of issues with, for example, heating or infestations, and they drive disease activity. It's interesting that I would say that probably sometimes things that cure asthma in some of our patients is just asking them to move from one place to the next, right? Sometimes it's like their own home is making them sick, and they move somewhere else, and their asthma disease is much better. And they're able to come off biologics, for example, sometimes. So It's definitely important. Perhaps the most clear aspect is housing, but there are other factors that involve this. There's a lot of work on, for example, like violence in your community, leading to increased symptomatology, and you wonder if, obviously stress can also be a trigger for asthma, right? So you wonder if that also contributes to this. So it's complex. And I would say that obviously in the clinic, we only see a snapshot of this complex patient. And the goal is to understand variability at the patient level to be able to make changes. Right? Great. Thank you so much. Thank you.
Jesse Roman,
Okay.
the former
Yeah.
started a tradition where everybody gets the tape to their lab.
Okay.
Oh
my God.
Of course, we'll send that to you.
Oh, this is amazing.
And then we'll get a picture.
Oh, I love it. Thank you so much. Oh, definitely. Yeah.
So,
Yeah. This is great.
I didn't want to show my ignorance in asking quite some gastroenterologists about asthma. I rescued a horse they were going to put down. I have a horse that had reactive airway.
Right.
And
So we're gonna send it to you. Jason is gonna mail it. So you're gonna hold this.
Yeah. That way I don't look like I'm back. All right, great, thank you. No problem. Thank you.
Somebody said, well, thanks. You know Keith Churchwell. I do. Not a nice one.